Welcome everybody to this web series, Recovery is Health, Health is Recovery. My name is Randy Pedersen. I'm the Syringe Exchange Program Manager in the Division of Public Health at the Idaho Department of Health and Welfare. I'm excited that you've joined us today, and as many of you know, September is National Recovery Month. This year, partners at the Idaho Department of Health and Welfare, Recovery Idaho, Idaho Harm Reduction Project, and the Northwest ATTC are collaborating to provide this Lunch and Learn series focused on health topics in recovery. So over the course of 6 sessions, we'll discuss topics ranging from harm reduction, infection prevention and treatment, and smoking cessation. These sessions will be every Wednesday and Thursday throughout September. So just a few housekeeping items before we introduce our speaker today and our topic. So I encourage you to introduce yourself to your peers in the chat, just to help foster community amongst us that are attending today. Please feel free to submit questions for the Q&A session at the end through the chat, or you can come off mute too at the end and ask your question directly to our speaker. A recording and slides will be available on the Northwest ATTC website shortly after this session. And if you attend the live session today, you'll receive a survey requesting your feedback and a certificate that you can use to obtain continuing education credit. So today in part 4 of our series, we will discuss smoking cessation. Our speaker today is Cass Adams. She is Project Filter's Health Equity Specialist and has been working in commercial tobacco prevention and control for over 6 years now. She supports communities across Idaho who are most targeted by the tobacco industry and have the highest disparities in commercial tobacco-related illness and nicotine addiction, including racially and ethnically minorized communities and people who are LGBTQ+. So addressing nicotine addiction in people with behavioral health conditions is really a passion for Cass, and she hopes that her work will make a positive difference for all people in Idaho. So welcome, Cass. I will hand the baton over to you.
Thank you. How is my sound?
It's good.
Sound okay? Good. Okay. Okay, and then tell me if you can see the slides or my notes.
Everything looks good, Cass. We can see the slides just fine.
Okay. Well, hello, everyone. I am Cass Adams. I'm the Health Equity Specialist for Project Filter. Project Filter is Idaho's commercial tobacco prevention and control program. As was stated in my bio, I've been working in nicotine addiction prevention and cessation for over 6 years. It has been a great pleasure of mine, both professionally and personally, to support individuals with behavioral health conditions. So thank you for giving me this opportunity to participate in Recovery Month. Recovery is health, health is recovery. Addressing nicotine addiction during recovery is one of many ways behavioral health professionals can support whole health and wellness for the people they serve. Before getting into things, I want to clarify just that any reference to the word tobacco in my presentation is referred to commercial tobacco made and sold by the tobacco industry and does not refer to the sacred tobacco used by some indigenous communities. So here's my purpose for presenting this information. Simply put, meaningful collaboration between public health and behavioral health professionals to address nicotine addiction in those living with substance use disorders and mental health conditions improves well-being, sobriety outcomes, and recovery. So here's a breakdown of what we'll be learning about throughout the day. We'll start by laying the groundwork with data. We'll look into understanding smoking and behavioral health, quitting and behavioral health, putting principles into practice, looking a little bit at cessation services and resources available, and how to get involved. So first off, we will lay the groundwork of this topic by exploring the landscape of smoking and its connection to behavioral health in Idaho. Most of the data we'll look at comes from the Behavioral Risk Factor Surveillance System, also known as BRFS, which is an annual health survey that every state in the country implements every year. If the data doesn't come from BRFIS, I'll try to point that out, but just in case anyone is wondering where the data is coming from, I thought I would let you know ahead of time. Okay. So in Idaho, about 13.6% of adults smoke cigarettes in comparison to approximately 12.5% of all adults in the country. So our rates are just like a little higher, you know, on average in Idaho than the rest of the country. I just want you all to remember, though, that this number is for the general adult population. Remember 13.6%, because in the next several slides, we will see that this number really doesn't tell the whole story. As of 2020, smoking rates vary somewhat by region, although the gap has actually lessened over time, which is good news. It's important to note that smoking rates vary even more, though, by county and even by neighborhoods. And there's a lot of data on this slide, but I want to just highlight the demographic breakdowns. As you can see, people who experience 14 or more mentally unhealthy days in a month, which is also known as frequent poor mental health, according to BRFIS, they smoke at a rate close to 25% compared to less than 13% of those who experience less than 14 mentally unhealthy days in a month. And mental health is obviously not the only factor that correlates with smoking. People with low incomes have much higher rates of smoking than those who do not have low income. Same for many other demographics, you know, including LGBT status, which is sexual orientation and gender identity, education level, employment. These disparities really are not coincidental, and they are not isolated. The tobacco industry specifically designs and targets their products to people they know are systemically and environmentally marginalized, and these demographics often actually correlate and intersect with one another. So it's definitely not in a vacuum. Now, here's a closer look at smoking rates among people with poor mental health specifically, again, defined as 14 or more days of bad mental health over the prior 30 days. Over time, we see that the smoking rates among people with poor mental health have decreased, which is good news. I guess the bad news, you could say, is that the smoking rate is still much higher, again, than those without poor mental health. Now let's explore the smoking rates among those with substance use challenges. Now, I want to caveat that the BRFIS data is fairly limited when it comes to substance use, but I'll show you what we have. Adults in Idaho who binge drink, which you can see there, binge drinking is men having 5+ drinks and women have 4+ drinks on one occasion. The rate of smoking in Idaho for adults who binge drink is 27%, which is lower than it was in 2021. Again, good news, but unfortunately, we kind of continue to see like some ebbs and flows in smoking rates. So we'll see the same thing here among the smoking prevalence with adults who drink heavily. Drinking heavily is defined by BRFIS as men having over 14 drinks and women having over 7 drinks in 1 week. So similar to the other slide, we see a lot of ups and downs, even more so really with heavy drinking. But as of 2020, which is our most recent data, around 29% of adults in Idaho who drink heavily also smoke cigarettes. And this slide shows us a little more about the correlation between smoking prevalence and other substance use items that are asked on the BRFIS survey. So people who use cannabis or marijuana, people who use prescribed opioids in excess and/or opioids that were not prescribed have higher rates of smoking than those who do not use those particular substances. One does not necessarily cause the other. Using these substances in the way that's asked does not necessarily cause smoking, but the correlation, I think, is pretty clear. And now here we see that there is a dose-response relationship between smoking and adverse childhood experiences. And for those of you who may not be aware of the term ACEs, I feel like most people at this point do, but they're traumas of neglect, abuse, violence in physical, sexual, or emotional forms that happen in childhood. The more ACEs someone has, the higher the smoking rate. And I just again want to reiterate that these do not cause smoking, but there is that correlation between ACEs. There's also, of course, a correlation between ACEs, poor mental health, and substance use. Health insurance is another factor that influences smoking. Those who don't have healthcare coverage have higher rates, which you probably could have guessed by now, considering the other disparities that we've explored. Now, before switching gears just a little bit, let's kind of just recap what we've learned. I went through that pretty quickly, but we know now that people who have poor mental health have high rates of smoking. In addition to that, there are a lot of other factors that are all interconnected that contribute to high rates of smoking. And these, on the slide include income, race, education, employment, sexual orientation and gender identity, even veteran status, and sometimes ethnicity. And with ethnicity, Hispanic adults actually have lower smoking rates than non-Hispanic adults. But when you look at it more by cultural background and country of origin, there are disparities there. Again, just the kind of one number doesn't really tell the whole story. Okay, so here we see that in 2018, over 15% of youth in Idaho had experienced major depressive episodes. I would imagine that that number is higher with the continued stresses that many of us are experiencing, pandemic, and many other things that youth are experiencing in their lives right now. Over 5% of adults have severe mental illness, and almost 25% have any type of mental illness. And again, this is from 2018. I would imagine that these numbers are probably a little higher now. I don't have those numbers for sure, but that would be my guess. So this slide actually breaks this down a little further by youth and adults with substance use disorders. So adults tend to have higher rates of overall substance use disorders, pain reliever use disorder, and alcohol use disorder, whereas youth tend to have slightly higher rates of illicit drug use disorders. Now, regardless of age, these numbers really show us the vital need for people like you providing these much needed services. Okay, so this slide is showing the prevalence of, on the left-hand side, it's showing the prevalence of people with behavioral health conditions. So, and this is actually, this is Idaho specific. The percentage of people in Idaho with behavioral health condition is about 25%. And the reason why it's about 25% just based on BRFIS, it's looking at anything that they constitute a behavioral health condition in BRFIS with the poor mental health and the various substance use disorders when you put them kind of all together. And many of them may have multiple at once. About 25% of people in Idaho in 2018 had a behavioral health condition. But on the column on the right, we see that those with behavioral health conditions actually smoke 40% of the cigarettes smoked. So there's definitely a disparity there as well. People with behavioral health conditions smoke more than those without. Now, this slide is not taken from BRFIS, and I can provide the resource to any of those who are interested. But this slide is really showing why addressing smoking and nicotine addiction is so important. Commercial tobacco use causes 540,000 deaths in the United States every single year. This includes about 40 to 60,000 people who die just from secondhand smoke exposure alone, many of which really have never even smoked in their life. Almost half of these deaths are among people with behavioral health conditions, and the total exceeds the death caused by many other things. So, unfortunately, people who recover from their behavioral health condition end up potentially the likelihood of, or the cause of their mortality is more than likely going to come from their smoking. And this really isn't to say that addressing other behavioral health conditions isn't important. It's not saying that addressing, these things that are on the right-hand column are not important to address. They certainly are. What this highlights is that smoking and nicotine addiction should be addressed in tandem, so alongside their behavioral health condition when possible. Now we'll conclude kind of our gallery, our data walk, with some good news. In Idaho, more people with frequent poor mental health tried quitting in the previous year than those who didn't experience frequent poor mental health. So really simply put, people with behavioral health conditions, they want to quit smoking. That's often a myth that has been perpetuated, is that people with behavioral health conditions, they just don't want to quit. I mean, the data shows, at least for this specifically, shows that people with behavioral health conditions who smoke really want to quit. So we will now explore further the connection between smoking and behavioral health by looking at why disparities exist and what we know about these two topics. And we'll kind of reiterate some of the things that we've already learned. So first is tobacco industry targeting. I'm going to talk about three main reasons why smoking rates are so high in people with behavioral health conditions, but the first reason is the tobacco industry. Big Tobacco has marketed their products as stress relievers, which is really only a partial truth, and I don't even really want to say that it's true at all, but now is really a good a time as any to talk about nicotine, which is the addictive substance in cigarettes. Now, nicotine is a highly addictive chemical. It's comparable with other drugs like heroin that we traditionally view as very addictive. Nicotine reaches the brain within seconds. And I just want to caveat, I'm not a chemist, but this is what I understand and what we know about nicotine. It reaches the brain very quickly, within seconds, causing kind of a high, in the neuroreceptors in our brains that make us feel better, right? So, but unfortunately, over time, the nicotine actually lowers the amount of neuroreceptors that actually help us feel good. So it kind of forces people to keep smoking to maintain that homeostasis, which is why you see people, and maybe even you yourself, if you do or have smoked before, know that smoking is so addicting that it, people who smoke oftentimes have to do it several times throughout the day just to get through the day. That is truly one of many definitions of what addiction really looks like. Eventually, really, it's the lack of nicotine that causes even more stress and cravings, and without it, the stress levels rise. Additionally, the high from nicotine also drops very quickly too. It doesn't last for very long. It creates that kind of vicious cycle. The tobacco industry has also specifically lied about the harmfulness and addiction levels of cigarettes, going so far as to providing cigarettes to treatment facilities and suggesting they be used as rewards for good behavior, or really as a way to keep people in treatment facilities like behaving. And that's really obviously a problem. The second reason why these disparities exist is because of structural and systemic disadvantages of minoritized racial, ethnic, sexual orientation, gender identity, and disability communities. There's probably more, but poverty, low education, food insecurity, housing insecurity, and job insecurity are all issues that stem from those structural and systemic issues, which also cause limited or no access to affordable healthcare. or safe built environments. So everything here is related. Now, finally, stress and trauma, adverse childhood experiences, like we talked about earlier, and other forms of childhood and adult traumas like violence, bullying, discrimination are all connected to high rates of smoking, poor mental health, and substance abuse. So here's what we know now, and a lot of these things are repetitive, but we know that nicotine is highly addictive, especially when it started early. When our brains are still developing and you start using nicotine products, they are even more susceptible to that addiction. And we know that people with behavioral health conditions have high rates of smoking. You know, we've learned that. We know that they smoke more often, and they actually smoke down to the cigarette butt more often than those who don't have a behavioral health condition. Unfortunately, people who recover from their behavioral health conditions can still die early from smoking-related illnesses. And finally, something that we haven't learned yet is that smoking and chemicals in cigarettes can interact negatively with treatment medications and therefore can actually interfere with recovery. And kind of similarly, recent studies, I actually just listened to a webinar about a recent study that showed that quitting smoking can actually have the same positive impact on mental health as medication specifically for mental health, which is really cool news. So more to come on that, I guess. I'm excited to learn more about that. Now there's more good news. I don't want this presentation to be all about, to be all negative. People with behavioral health conditions want to quit. Not only do they want to, they really can quit. And again, this is a stereotype or just a thought process that has been perpetuated over time that people with behavioral health conditions just don't want to, or they just can't do it. They might need more intensive support than others, but they can quit. And quitting smoking during treatment can improve recovery and sobriety outcomes. That's like, if you learned anything today from this presentation, it's this: quitting smoking during treatment can improve recovery and sobriety outcomes. And at the very least, it does not hinder recovery. That is something that the tobacco industry has perpetuated for decades at this point. And then smoking is just simply not necessary to cope with the challenges of recovery. Again, despite what the tobacco industry would like us to believe, I don't blame behavioral health professionals for this. I don't, there's no blame put on the people working in this setting by any means. It really is something that has stemmed from an industry that profits off of addiction. And so quitting is really part of the right path. It's not the only thing that needs to be done, but it is part of the right path towards long-term recovery. However, we recognize that this is not easy. Quitting with behavioral health conditions, while not impossible, can be very, very difficult. So let's learn more about this. Approaching treating nicotine addiction is very similar to other SUDs and mental health conditions. You don't really have to do a whole lot too differently. Tobacco use disorder is an actual disorder that is often underdiagnosed and undertreated. That being said, we know that addiction is real. Addiction to nicotine is an addiction. Nicotine is, again, one of the most addictive substances, and I've talked with many people who say that quitting smoking was actually one of the hardest things they've ever done, and that it has given people hope that they could also recover and thrive without other substances as well. Now kind of moving on, the choice to try quitting is theirs. It can't and shouldn't be forced, just like, forcing treatment upon someone for other things. It just doesn't work. And it's one step at a time. You take it one step at a time. Slip ups, which is when you try quitting, you smoke again, but then you go back, to to try quitting again. So slip-ups, relapse, when you try quitting but start smoking again and don't start trying to quit again. Neither of those things are failure. It's really a normal part of the quitting process. It's normal to feel cravings. It's normal to slip up or relapse. It can take many, many times to try to get there. Withdrawal symptoms are really common, but they don't last forever. And then counseling and medications work to help people quit. Using medication to help people quit smoking is essentially, medicated assisted treatment. And I know probably all of you are familiar with that. And alongside counseling, the likelihood of a more successful quit goes up. And then, of course, we can't talk about this without talking about peer support is a vital part of success. Okay. All of this being said, we do need to acknowledge the challenges that come with quitting smoking with a behavioral health condition, both perceived and actual losses experienced while quitting. So people who try quitting may lose some of the important social interactions with those who still smoke because they just can't be around people who smoke. It's too much of a trigger. We've heard time and time again that this is their last, their one last vice, and we shouldn't take away their only way to cope with stress. But at the end of the day, those are really only a perception because quitting actually improves mental health, and less maladaptive coping strategies can be taught, they can be learned. Of course, those are not the only challenges. There are others too. With how highly addictive nicotine is, quitting is not just a matter of willpower. And then in many behavioral health settings, smoking is socially acceptable, it's common. Some of you might have even questioned the data that 25% of people with behavioral health conditions smoke, because in some treatment facilities, you might see that everyone smokes. So it's really common. And oftentimes, for understandable reasons, the immediate impacts of addiction and mental illness are considered higher priorities. Again, that's, I think, very understandable. The long-term effects of smoking tend to be ignored, while the potentially negative acute impacts, or the really immediate impact of other addiction and mental illness, are addressed. I challenge folks to consider how both can be considered at the same time, at the appropriate time. For example, someone coming into a crisis center for suicidal ideation that's not the appropriate time to ask someone about smoking and if they want to quit. But as a client becomes stabilized, they get the help that they need, then there might be an appropriate time a little later to start talking about that. And I finally also challenge the final challenge, and I know that there's many more, but the last one that I'll talk to you all about is the lack of smoke-free spaces. When people are surrounded by smoking, it does make it harder to quit. I mean, that's just the reality. So we have to acknowledge the challenges. We can't just pretend that it's easy. We can't pretend that there's nothing that won't be difficult about these experiences. But let's reframe and talk about the benefits of quitting smoking during recovery. So people who quit tell us that they feel like they have more control over their lives, over their choices, their finances. They feel less anxiety, less depression, their mental health is better. There are both immediate and long-term health improvements. Our bodies start healing right away. Like as soon as we start going without cigarettes, our bodies start healing immediately. But there's also those long-term physical health benefits. Improved immunity, wound and injury healing improves, chronic disease prevention. I mean, those are all really important things. Of course, everyone has to find their own reason Physical health benefits may not be the reason why people choose to quit, but it's a benefit that will come regardless. Overall quality of life is improved, and as we've already discussed, recovery and sobriety outcomes can be more successful. Okay, so all of this information is great, but how do we actually help people? Let's explore putting these principles into practice. I'm going to check my time as well. Okay. So here are some considerations for nicotine addiction treatment. Before beginning any sort of process and before kind of putting any of this into practice, here are some questions to consider. Does your place of treatment or recovery screen for nicotine use? Does your place of treatment or recovery actively encourage and provide resources for people who say they want to quit? Do staff in your place of treatment or recovery smoke in front of clients or patients or anywhere on the property? Does your place of treatment or recovery have a smoke-free policy? Is it enforced? What is your place of treatment or recovery's capacity to integrate tobacco cessation? And similarly, is there support in your place of treatment or recovery? So support or buy-in to integrate tobacco cessation. So these are just some important questions to think about when you're wanting to maybe make some changes to your place of work. Okay. The first thing that can be integrated is a framework for nicotine addiction support into your already existing practices. The framework we suggest is Ask, Advise, Connect. There's Ask, Advise, Refer, 5 A's and an R. There's like a variety of similar frameworks. We like Ask, Advise, Connect because it really is the most simple. It's designed to take a minimal amount of time and is easily integrated again into already existing practices. The integration of Ask, Advise, Connect can be an objective or an activity for any potentially quality improvement requirements you may have through your funding. This framework improves the likelihood of a successful quit because it's formal, it's evidence-based, and it's just really another tool in the toolbox to improve the well-being of patients and clients. So going back to the theme of this recovery month, recovery is health, health is recovery. Quitting smoking is part of healthy living, it's part of recovery. So let's dive a little bit deeper into Ask, Advise, Connect. Ask just basically means that you screen for nicotine use and readiness. Readiness shouldn't be forgotten. So screening for nicotine use and readiness to quit during intake for services. An example of this may look like, do you smoke cigarettes, vape, chew, or use a different kind of vaping product? And then following up, do you want to quit or reduce your nicotine use? It's important to ask these questions at every follow-up. It's not nagging. Someone who might not be ready the first time they're asked may be ready the 5th time, the 10th time. So it's really important to ask every time. In Idaho, about a little over 80% of treatment facilities do identify commercial tobacco users. So that's like a great start. The majority of places in Idaho are already doing this in some form or another. Okay, next is advise. This is just essentially encouraging quitting, addressing myths, challenges, and benefits. So we talked about all of those things in depth throughout this presentation. We want to acknowledge them. They say they want to quit, but they have reservations. They aren't sure. They have questions. That's all okay. It could look, something like this. Connecting the advice to the reason for them being in treatment. So, for example, quitting smoking can be hard, but it can help you on your recovery journey. That's a very simple way to frame some of the challenges that folks might have or concerns that folks might have about quitting. It's also important to address clients' concerns with compassion and validation. So we never want to diminish someone that has those questions or concerns. We should address them with compassion, utilize the information that we've learned today. For example, smoking can feel like your only way to cope, but we will help you build healthier coping skills. So the concern might be, this is the only thing that makes me feel better, but you know, the response to that can be, we're going to help you find those other ways to help you feel better or to deal with stress. And finally, the third part is connect, which is just referring cessation services or offering direct treatment. Project Filter, which is the organization that I work for, offers free services, and people can be referred to our services via fax, web, or e-referral. I'll discuss that and kind of our services a little more in depth in just a few minutes. But direct services can also be integrated into your existing practices. It looks like helping people quit with peer support, with group sessions, individual counseling, and also, you know, providing quit medication. In Idaho, 25% of treatment facilities provide evidence-based counseling for smoking cessation, so only about a quarter. 11% offer medication, which has improved over time, but only 4% bill for tobacco cessation services. So while there's a lot of places that are asking about it, as we kind of go through these steps, we see that less and less folks are following all of these steps. So there's definitely room for improvement. Now, adopting smoke-free policies is another way to support clients in going smoke-free. The benefits include a reduction in exposure to secondhand smoke. It can be encouraging to those who are trying to quit, and it fosters a substance-free environment. But some considerations include using non-punitive and encouraging language in the policy and on any public signage. These policies should include all nicotine products, including vaping, again, to foster that substance-free environment. And enforcement, and I don't love to use the term enforcement, but it should be consistent across all people, including staff, patients, and visitors. And it should really never be about shaming the smoker, but providing an environment that embodies wellness in all forms. We also want to avoid pushing people to smoke in other places off-site that may not appreciate smoking closer to their, buildings, businesses. For example, businesses or homes nearby could be impacted by secondhand smoke if smoking is pushed too far away from where your setting is at. So talking with your business neighbors and just considering kind of the environment of the building itself is important. Project Filter offers free customizable smoke-free signs for those who would like to explore this option. There is entire trainings just about this very topic. So obviously we don't have time to go into this, but if anyone has any questions about this, please feel free to reach out. This especially can be very challenging, but it does, like I said, it does foster wellness, as kind of part of the other things that you do in your organization. Now, here are 10 steps that I recommend to achieve the things we've been talking about. And the first one is getting buy-in. Convening or involving a wellness committee or some sort of committee in your organization that is already talking about wellness in whatever capacity that looks like for you. It's so important to get that buy-in from staff, leadership, clients, visitors. It won't do anybody any good to just kind of force these things upon other people. Getting that buy-in is really vital. Creating a timeline for implementation, not just doing it right away. Crafting the message, like what is the purpose, which is also part of number 5, but like really what's the message that you're trying to send by implementing these changes. Drafting the policy, and again, the policy should really also be very clear and include the purpose, and then once the policy is drafted, you can more clearly communicate your intent and your purpose, which at the end of the day, however you want to put it, is really about the wellness and health of your clients. Educating staff and clients is, really essential throughout the entire process, but, it's kind of put in here. Provide cessation services to staff. Staff may smoke, and that, it's not about punishing them. It's not about forcing them to quit, but providing cessation services to them or providing resources to help them will go a long way. Build community support if needed, launch the policy, and then don't just let it sit, monitor it, see how things are going, adapt it, revise, respond to anything that comes up. Okay. So I know that was really quick. And again, this is all things I would be more than happy to discuss with people individually. As promised, let's discuss the free cessation services and resources offered by Project Filter and our partners throughout the state. So the Idaho Quit Line, which is our telephone service, is open 24/7. There's a language line with translation services for literally any language, and a TTY number for deaf and hard of hearing. There's up to 8 weeks of nicotine replacement therapy, which is in the form of patches, gum, or lozenges. And folks who want to participate in our behavioral health program, which I'll talk about on the next slide, that is specifically a phone program. But if they want to participate in other programs or the general program, they can sign up online at projectfilter.org or over the phone, whichever one works. So here's some more information about the behavioral health program. It's a compassionate and intensive support program through the Idaho Quit Line, specifically for people with behavioral health conditions. And that's listed as depression, anxiety, PTSD, bipolar disorder, ADHD, schizophrenia, or substance use disorders. And just again, it's available for people ages 18 plus over the phone. And they also are eligible for the up to 8 weeks of patches, gum, or lozenges. And really, they probably will come dually. So a patch and a gum, or patches and a lozenge. Now, supporting treatment for youth, we have a My Life, My Quit program, but it's specifically for folks under the age of 18, so 13 to 18 years old. And while we can't offer nicotine replacement therapy to people under age 18, they also receive the personalized free help from a trained quit coach. And what's unique about this program is that they can actually access it via text, chat, or over the phone. I don't know a single teenager that would want to call a quit line, but that option is available. It's confidential, which is really good for a lot of young people who maybe don't want their guardians knowing about their quit journey. So mylifemyquit.com or texting Start My Quit to 36072 is how youth can get that cessation support. Now, like I kind of mentioned a few slides back, there are 3 ways for providers or for people working in behavioral health settings to refer their patients or clients to the quit line. There's fax pads. We provide free fax pads. We can mail them to you. We can even have some of the information built in and printed and sent to you so that you have to do less writing. There's also web referrals at projectfilter.org/HCP. And then there's e-referrals, and e-referral is basically just integrating our quit line directly to your EHR, and we cover the cost of implementation. We don't necessarily cover the cost of any annual fees that are related to your EHR, but it's kind of more just a click of a button. Information is sent, and it's HIPAA compliant, sent to the Idaho quit line directly. So it's really the fastest way. And then once the quit line receives any of these referrals, they then call the client that's referred up to 5 times. They'll leave voice messages requesting callbacks and until they can get in touch with the client. So those are the 3 main ways to do direct referrals. Now, Project Filter also partners with our 7 local public health districts. They offer one-on-one, group, in-person, and virtual cessation programs. They also implement what we call the diapers and wipes program for people who are quitting in the same home as a pregnant person or a newborn. They just engage in basically testing to stay smoke-free. They get connected to some sort of cessation service, and then they're eligible for a free big box of diapers and wipes every month they come in and test free of nicotine use. They also engage in commercial tobacco prevention efforts with educational presentations and tobacco-free policy assistance and signage, just like we do. 211 is really the best way to get in touch, but if you're interested in working with the public health districts at all, just let me know. I can find the specific contact for you. Now, here's some free resources for providers. These are all free, and it's not even, this list is not comprehensive. If you go to Idaho Health Tools, I just Google Idaho Health Tools. It's a resource that has free materials that can be mailed to anywhere throughout the state of Idaho. And it's not just our program stuff, it's a lot of different public health programs have resources available. For us, we provide a behavioral health program flyer, poster, and brochure. We have My Life, My Quit, which is the youth cessation program. We have posters and bookmarks. We have just general English and vaping brochures, which walk through all of our different services and provide some tips and support on how to quit. We have our general, that was English and Spanish vaping brochures. We also have general program brochures in English and Spanish. We also have wallet cards that, instead of going in depth with our services, it's just something that can fit in someone's pocket or wallet. We also have a healthcare provider toolkit and a behavioral health toolkit. And all of these, again, can be ordered on Idaho Health Tools. And I believe somehow you will either be able to access these slides later or this recording later. These links, these training and continuing education opportunities, the first one is Quit Logics, which is our Idaho Quit Line website. This link has free CEUs, and then the link below it also has free CEUs through the Smoking Cessation Leadership Academy, which is a national organization. So how can you get involved? So, we've already talked about a lot of things that you can do in your own organization, but there's also things that you can do to get involved in the statewide effort to reduce the disparity of nicotine addiction in people with behavioral health conditions. So an action planning summit, which was the Idaho Leadership Academy for Wellness, Nicotine Addiction Recovery, and Smoke-Free Living, was held on August 31st and September 1st. And it included a wide range of behavioral health and public health professionals. 4 work groups were established: data, education, policy, and health systems change. And we sat down and we developed an action plan on how we can achieve a nicotine-free Idaho for people with behavioral health conditions. We established goals that we would like to see a 10 percentage point reduction of smoking in people with frequent mental health, and people who smoke who also binge drink. So we really need your help. I mean, we feel like everyone has a role to play, but no one has to do it alone. So if you are interested in being involved in any of these work groups, or just kind of want to learn more about the summit, the Leadership Academy, please contact him. Now, before opening up for questions, I'm just going to look at the time. Very quickly, I would like to show you all a video, just kind of as a final wrap up to this presentation. So I'm going to stop sharing and then share again the video. Let's see. Am I sharing? Can someone let me know if I'm sharing my screen or not? I feel like I'm doing something wrong.
Not yet. Not yet, Cass.
Okay. Thanks. How about now?
Yes.
Okay. And then let me know if you all can hear.
When I was a teenager, I got depressed.
Sounds great.
And I picked up a cigarette. And it snowballed from there. I called Quitline
We're here to listen to you.
because I could not stop.
That tells me this must be important for you.
I needed support.
We really want to do it in a way that works for you and will fit in with your own schedule.
You can tell them what you're experiencing. You can tell them how hard it is to quit. When I called Quitline, my whole life changed.
Do you just want one scoop?
It was like someone threw me up a life raft. It's wonderful. Please call Quitline. It's given me my son back.
I am proud of my mom.
When I
Okay, well, thank you everyone for your time. I will open my PowerPoint back up really quickly so that you can see my contact information. And I can also open it up to questions.
So, Cass, is vaping a good way to work toward quitting?
It's a great question, Norma. I kind of alluded a little bit to that when we talk about smoke-free policies and making sure that vaping is included in smoke-free policies, that, you know, we don't want vaping around either. We don't recommend using vaping as a way to quit because we don't have enough information yet, enough research to determine if vaping really is a good way to support people in quitting. There are ways that we do know. The medicated assisted treatment, essentially with patches, gum, and lozenges alongside counseling, is the best way to help people quit. What we know about vaping is that it's still highly addicting. There's nicotine. It's a lot harder to control how much nicotine you're receiving when you vape. That being said, vaping is not as harmful. And I say that very carefully because it still is harmful. So no, we don't recommend it, but we also know that there's some harm reduction there. At the end of the day, the addiction to nicotine is there with vaping or smoking it. You know, they're both the same. They're just a little different delivery.
If people have questions, put them in the chat, or you can just unmute yourself. I think they can, and ask them directly.
Yeah, I'm seeing in the chat if slides will be available, and I will definitely share these slides with ATTC so that they're available at the link that was just shared in the chat box.
Well, I'm not hearing a lot of questions. I think you were just very thorough, Cass. Thank you so much. It was such a wonderful presentation. And in lieu of questions, I will just go ahead and wrap us up for the day. As a reminder, for those of you that attended the live session today, you'll receive a survey requesting your feedback and a certificate that you can use to obtain continuing education credits. And we certainly invite you to join us for part 5 next week, where we'll talk about sexual health and recovery, and specifically focus on sexually transmitted infections. And that presentation will be on Wednesday, September 21st at noon Mountain Time. You can register on the ATTC website. So thank you again so much, Cass and Norma, for joining us today. And I wish you all a great rest of your week and a great weekend.
Thank you. Thank you so much.